Thank you, Chair. Today, I'm going to talk about hemoptysis after Tevar treated by Bae. This is my COI. Hemoptysis after Tevar is rare but can be fatal. The most common cause is aortobronchial fistula or AVF. Tevar-related fistulas can involve various structures. The aortobronchial fistula or AVF is the most severe cause of post-Tevar hemoptysis. AVF or aortobronchial fistula is the most important cause of hemoptysis after Tevar. The yellow arrow shows a shoot aneurysm. Let's move on to the case. Our case is a 60 years old male presenting with mild hemoptysis. 12 years post-Tevar, 10 years post-PDA, undergoing maintenance hemodialysis with heparin, and no evidence of AVF on CT. So he was referred to our heart center. On the corner CT on the right, you can see a ground glass opacity adjacent to the stent graft, suggesting bleeding. The actual CT shows consolidation around the stent graft in the left lower lobe, suggesting bleeding. This FDG PET CT shows follicular uptake near the distal stent graft, suggesting a localized inflammation. However, this finding alone was not sufficient to confirm AVF. No shoot aneurysm or contrast enhancement was identified at the site of PET uptake. Therefore, AV was not demonstrated. On this 3D CT, we identified a very fine ectopic contralateral bronchial artery BA1 shown in blue. However, it was not significantly dilated and seemed to be cut off at this point. Therefore, at this stage, we could not be certain if this was the true source of the bleeding. Further evaluation of the 3D CT revealed another ectopic contralateral bronchial artery designated as BA2 shown in purple. However, this vessel was even thinner than BA1, and just like BA1, it also appeared to be interrupted mid-course. Contrary to CT findings, angiography confirmed BA1 was continuous, reaching to the left lung via the mediastinum. This is a video of the same finding. BA1 was successfully embolized with coils. BA2 showed the exact same pattern, proving to be another source of the hemoptysis. Therefore, BA2 was also embolized. Let's look at the outcome. No recurrence of hemoptysis for 11 months. Let's move on to the discussion. Bronchial and intercostal arteries, key vessels supplying the aortic region and commonly involved in hemoptysis, are frequently occluded after Tevar. This may be due to, first, coverage by the stent graft, second, preemptive embolization for type 2 and leak prevention, third, nature of the original aneurysm or dissection. What, then, becomes the source of hemoptysis after Tevar? Following Tevar, culprit vessels for hemoptysis often originate from alternative non-aortic systemic sources, including these arteries. This is a different clinical case. An ectopic bronchial artery from the contralateral side can be a potential culprit in persistent hemoptysis. This is a definition of BA. I think I'll skip this slide in the interest of time. In Then on the left side, on the left, a simple ectopic right bronchial artery originating from the left subclavian artery. And on the right, collateral circulation from an ectopic right bronchial artery arising from the right subclavian artery to the occluded left bronchial artery. In the present case, the left bronchial artery was presumably occluded through the mechanism described earlier, leading to collateral circulation from a right ectopic bronchial artery to the left lung. This slide shows the law of 3D CD angiography, invaluable for identifying ectopic origins and planning deembolization. One crucial tip is that vessels may appear interrupted on 3D reconstruction even when they are actually continuous. This slide shows the clinical significance of aortic angiography. Comprehensive evaluation is essential when AVF is not demonstrated. Contralateral bronchial arteries should be actively searched for as potential sources of systemic to pulmonary shunts. This is my conclusions. Thank you for your attention.